Good morning. Thank you, Annette, for inviting me. I have a deep-rooted love for fundus autofluorescence. However, this paper I chose out of my blinded love for it might change my mind. So we all know the principle of autofluorescence is detecting lipofuscin in the RPE. And lipofuscin is a fluorophore produced by degradation of photoreceptor outer segments and certain reactions of vitamin A aldehyde. And it accumulates in RPE either physiologically with AID or pathologically in certain retinal degenerative disorders, whether AMD or dystrophies such as Stargardt's. And then there are other minor fluorophores, and we're going to discuss these later on. So lipofuscin can fluoresce, and its spectrum of excitation is within the blue-green portion, 300 to 600 nanometers, and its emission has a wide range between 480 to 800. However, the emission signal returning back from the RPE is around 2 magnitudes weaker than that of a fluorescein angiogram. So it was always difficult to detect. Until the confocal scanning laser ophthalmoscope was developed, which uses pinhole optics, and the Heidelberg retinal angiograph uses the shortwave or the blue wave excitation. And it uses a laser with excitations and barriers similar to fluorescein angiography. And the normal shortwave autofluorescence, this is its appearance. The optic nerve head appears dark because of absence of RPE. The blood vessels are also dark due to absorption of the light by blood. And the central macular area has reduced foveal autofluorescence due to absorption of the exciting light by the macular pigment and their higher optical density of melanin. And the autofluorescence is the highest between 5 to 15 degrees from the fovea, as it has the highest density of broad outer segments. And this is as we age, the autofluorescence decreases as the amount of lipofuscin in the RPE increases, and it occupies almost 1/4 of the cytoplasmic space. Normally, in drusen appear mildly hyperautofluorescence, and it was noted that with drusenoid PED, an increased number and size of drusen, there is an increased risk of disease progression. It was extensively studied the junctional zones of geographic atrophy, the area between the normal and the atrophic retina, on fundus autofluorescence, and it appears hyperautofluorescence in contrast to the hypoautofluorescent area of chorioretinal atrophy. And it was found that the banded pattern or the diffuse pattern had a greatest risk of disease progression. So coming to the color fundus autofluorescence, this is a novel shortwave confocal blue autofluorescence system. And it uses a shorter excitation wavelength, 450 versus 488 in the conventional blue shortwave autofluorescence. And it has two different emission spectral channels, one for the shorter component, or the green, and one for the longer. And it allows visualization of minor chlorophyls who on normal blue shortwave autofluorescence would be completely overwhelmed by the lipofuscin. And these include advanced glycation end products, vitamin A derivatives, fatty acids, extracellular proteins such as collagen, intracellular proteins such as cytokeratin. So the article I chose is one that was published in 2021 about color fundus autofluorescence to determine the activity of macular neovascularization and age-related macular degeneration. Keep in mind there is a total of 6 studies about this color fundus autofluorescence. 2 related to geographic atrophy, 1 related to neovascularization, 1 related to healthy patients, 1 related to diabetes, and 1 related to posterior uveitis. So it was a prospective observational study and included 137 eyes, either with unilateral, bilateral macular AMD, with or without activity, treated or not. Pseudophakia or early cataract allow optimal visualization, and they excluded any other maculopathies, previous surgery, drugs, or poor quality image. And they subjected each patient to a hefty, costly array of imaging, included fundus photos, swept source OCT, OCTA, autofluorescence, and angiography was their first diagnosis. And this color fundus autofluorescence is in Eden, produced by Eden in Italy, and it uses, as I mentioned, a shorter wavelength for excitation. And then the images are detected on a color sensor and are consistent only of red and green components. And it has an automated segmentation tool, which quantitatively measures the red and the short and the green wavelengths and the exact fluorescence intensity. And at each point, it can tell, it plots an XY graph of this. So it takes, in the study, they took 4 different sites, each 5 by 5 micrometers, and they calculated in it the mean, median, and range of the autofluorescence wavelength and the intensity of the green and red components. And they correlated them whether this is a site of the membrane itself, hemorrhage, subretinal fluid, PED, fibrosis, or atrophy, and they compared them by comparing them with color photo OCT and OCTA. These pictures of how it's done aren't from the study, but from the studies by Borelli, 2 major studies done about it. I think the second picture describes it most. The other one is the color fundus autofluorescence, and then they split it into red and green, and the bottom ones show the emissions of each. In this study, for instance, they take the site of chorioretinal atrophy and relate it to a macular neovascular membrane, and each point in the asterisk, they calculated the autofluorescence wavelength, the green emission fluorescence component, and the red emission fluorescence component. So the results of the study, so they excluded 26 eyes, which is not a small portion, due to poor quality or large scars, and they had 57 active eyes and 40 inactive ones. And they found that in cases with associated subretinal fluid, they had higher values of green and red fluorescence intensity, and their emission wavelength was significantly lower than atrophy and lower but not significantly than fibrosis. They didn't find any difference between type 1 and type 2 macular neovascular membrane, and between active and inactive macular neovascular membranes, they found that the autofluorescence wavelength of that with both subretinal and intraretinal fluid was significantly lower, but macular neovascular membrane with subretinal fluid had significantly higher values of green and red emission fluorescence, and that with intraretinal fluid had higher mean value of green, significantly higher mean value of green emission fluorescence component, and an increasing trend for red emission fluorescence component. And these are pictures from the studies showing that on the left hand showing the active neovascular membrane with the subretinal fluid, with at the sites of the black arrows is the autofluorescence, and it's much higher than inactive ones, sorry. Likewise in the second case. So anyways, as I mentioned, there's very few studies about this, and including 3 by Borelli, in which he discussed trophic age-related macular degeneration in 2 of them, and in 1 of them he used healthy eyes in which they were examined 1 week apart to determine the repeatability of the green emission fluorescence component, and found that they were highly repeatable and reproducible. So what we need to know, the autofluorescence value is an average. So for instance, it might be a single emitted wavelength from the lesion or 2 different wavelengths of equal components. So we can't use this wavelength as identifying a component. Is this a macular neovascular membrane? No, it won't tell us. So for instance, in subretinal fluid, it has a wavelength similar to fibrosis and atrophy. However, it has a much higher red emission fluorescence component. So maybe this would be a clue, but we don't really need it when we have OCT and OCTA. So subretinal fibrosis had a higher fluorescence emission, a higher intensity in the red emission fluorescence component, and it said that that meant that there were more fluorophores that were present and excited in comparison to intraretinal fluid. And Borelli also tried to eliminate this red emission fluorescence component by only using the green emission fluorescence component in areas of atrophy, and found that there still was a signal due to presence of hyperreflective material overlying the Bruch's membrane or residual or regressing drusen. When they compared the macular neovascular membranes with subretinal fluid or intraretinal fluid, in general, intraretinal fluid is associated with signs of chronicity, lower best-corrected visual acuity, and found that the green emission fluorescence and red emission fluorescence were lower than that with subretinal fluid as a more chronic disease. So if we go back and look at what the standard shortwave blue autofluorescence would show us in neovascular AMD, usually the neovascular membrane appears hypoautofluorescence due to blockage of the autofluorescence of the RPE. And the increased pattern of autofluorescence found in it might be at the site of subretinal fluid, as in this study, and in the edges of the CNV membrane. And that's just due to accumulation of lipofuscin. And the decreased autofluorescence corresponds to a scar, atrophy, blood, or pigmentary changes. So there are multiple limitations to this study, including the intrinsic limitations of how they were imaged. For instance, they excluded any case with cystoid spaces because they couldn't actually isolate the lesion. And there was a lack of longitudinal data, and they could only include patients with pseudophakia or mild cataract for proper imaging. So in conclusion, they concluded that there were significantly different results for active versus inactive macular neovascular membrane. There are no differences between type 1 and type 2. And if this data can be confirmed, we could use color fundus autofluorescence with an easy and fast single-shot acquisition to detect active macular neovascular membrane. Do I believe that we can differentiate between active and inactive by color fundus autofluorescence? No, I think that's looking through rose-colored glasses. And maybe we can use this for dystrophies that we do need to identify the minor fluorophores for. And when I researched this, I didn't find anything about it. And possibly drug toxicity that would affect the minor fluorophores versus the lipofuscin. Maybe at that point, it would have a significant clinical application. And thank you for your time and for tolerating my notorious rainbow-colored headings. Thank you.
Thank you, Dr. Lamis. So very quickly, Dr. Mahmoud, I personally routinely use autofluorescence in all cases of dry AMD in order to highlight the extent of the GA and predict areas which are going to develop GA in the future. So this is what I personally use. Do you use it for anything else other than that?
Well, autofluorescence يعني something fundus autofluorescence is it gives you أنا كمان كده okay, all right. So well, it gives you an idea about the health of the retinal pigment epithelium and how things are, and you'll be surprised sometimes you can see some pathologies which are not evident when you just examine the patient. So fundus autofluorescence is important. It's one of the multimodal images which we should rely وبقت موجودة دلوقتي في معظم الماشينز. Ask for it, look for it, and يعني what you are reporting now is interesting, and it might add something new to our armamentarium. Of course, you can see our search for activity by different the intraretinal fluid, the OCTA. So we have a few options to seek. Yeah.
Thank you, Dr. Mahmoud.